Well, good evening, everyone. It gives me great pleasure to welcome you to tonight's topic, meningitis B vaccination through general practice, funded program insights, and patient engagement strategies in risk groups. My name is Associate Professor Roy Rasalam. I work at Alfred Health Endocrine and Diabetes Department in Melbourne, Victoria, and I'm also affiliated with the University of Melbourne. I'm a clinician researcher and run phase 1B to 3 randomized controlled trials, including vaccine studies at Sunshine Private Hospital. And I'm delighted to be chairing tonight's meeting. In the spirit of reconciliation, the Immunisation Coalition and myself acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. We are here tonight as a multidisciplinary group to discuss protection against a very important disease, meningococcal disease, and we're having a special focus on meningococcal B disease and how that can be protected through vaccination. Tonight we'll be covering the following areas, and these are in the flyer that went out regarding the event. So topic 1 is the epidemiology and burden of meningococcal disease in Australia and of the different disease-causing meningococcal strains. Topic 2 is summarizing the NIP eligibility criteria for meningococcal disease and recommendations supporting vaccination outside of the NIP. Topic 3 is examining current state and territory funded programs on meningococcal B and the success of these programs. And topic 4 is a very practical topic, I think, which is exploring the use of key messages when discussing meningococcal disease and meningococcal B vaccination to help address questions, objections, and concerns. As a reminder, tonight's webinar is a RACGP accredited activity. GPs will also be sent a practice audit activity on meningococcal B vaccination, and it is accredited for 3 measuring outcomes CPD hours. If you don't want to do the activity, you can, of course, get the 1 hour of educational activity. So joining me tonight are 3 healthcare practitioners who will share their knowledge and experiences on meningococcal disease in the clinic setting. So in no particular order, firstly, Professor Robert Boy is an honorary professor of pediatrics and child health at the University of Sydney. Robert has held many senior roles, including, but not limited to, Research Fellow at the NCIRS Westmead Children's Hospital. And he's a pediatrician and an infectious diseases expert at Mary's Hospital, London, and John Radcliffe Hospital, Oxford. Robert's key interests are in the susceptibility to and severity of infectious diseases, namely influenza, pertussis, and meningococcal disease. Professor Boy is also the chair of the Immunisation Coalition Scientific Advisory Committee. Welcome, Robert.
Thank you.
Our next panelist is Sonia Elia, and Sonia works at the Royal Children's Hospital Immunisation Service, and in 2017 became Victoria's first nurse practitioner in the field of immunisation. She has a particular interest in vaccine hesitancy, special risk groups, needle phobia, and immunisation education. Sonia has received multiple awards, including the Dame Elizabeth Murdoch Nursing Development Scholarship and the Royal Children's Hospital Chairman's Medal. And she is a teaching associate with the Monash University and holds honorary positions with the University of Melbourne and the Murdochs Children's Research Institute. Welcome, Sonia.
Thank you.
And finally, but certainly not least, Dr. Leanne Jones, who is a general practitioner at the Windmill Hill Medical Centre in Launceston. Leanne has over 35 years' experience as a GP and has an in-depth knowledge of the health issues facing Tasmanians. She has a special interest in immunisation and sits on various immunisation advisory and reference groups. Leanne is also a director of the Immunisation Coalition and sits on the board. Welcome, Leanne.
Thank you, Roy. Welcome, everyone.
So tonight we will be taking online questions throughout the evening. So please use the QA function as we discuss topics, and we will do our best to answer as many questions as possible. The entire meeting is being recorded and will be available on our website in about a week. Finally, we would like to acknowledge GSK for supporting this educational activity. So now let's get started. So I might like to start this evening by opening the questions with Robert, if I may. So Robert, let's get down to basics. What is meningococcal disease? Is it a bacteria? Is it a virus? Is it fungal? And how is it transmitted?
Hi, Robert Boyce, my name. Meningococcal disease is a bacterial infection which starts off in the throat as a colonizing event without really any symptoms. But up to 1 in up to 1 in 5 people, 20%, if you're a teenager, can carry the germ in the throat, and a very small minority of those can allow invasion of the germ into the bloodstream, up to the brain, or around the body to cause septicemia or meningitis. Now, meningococcal disease is a bacteria that has an outer coat, a capsule, and that capsule is purified for the different serotypes that there are, like A, C, Y, and W, to make a vaccine, which is very effective against all 4 of A, C, Y, and W. But by far the most common meningococcus serotype at the moment is B, which accounts for 80 to 85% of cases in Australia right now. And it's the one we're most worried about by way of causing invasive meningococcal disease, which we would hopefully be able to prevent in the not too distant future with a vaccine rather than trying to identify it early.
And Robert, what would be the commonest mode of transmission?
So transmission is, I'm sorry I didn't answer that, it's really important. It's all about close contact, as with many infectious diseases. So if someone coughs on you, kisses you, hugs you, you can spread the bug in the saliva of the person who's carrying the germ to the person who then receives it and gets infected and can get invasive disease. So we did research in the UK where I worked for 15 years, and we showed very clearly that kissing contacts, multiple kissing contacts, not just one person but 2 or more, increased your risk substantially. Having a viral respiratory infection which damaged your throat also allowed the bacterium to invade. And also being exposed to another person, say a teenager or an adult, who was a smoker, they're more likely to carry the germ, they're more likely to cough. So smokers cough and transmit the bacteria to susceptible people, just as can happen with close personal contact and with kissing and cuddling and as I mentioned. So those 3 means of transmission, which we recognise with other infections as well, are important for meningococcus.
Robert, in terms of the epidemiology of the disease, what's the burden of disease in Australia, and has it changed over the past decade?
We've had a number of changes over the last decade because of COVID. All around the world, the incidence of meningococcus went down in 2020 and 2021. But once we then allowed more mixing of people in 2022, countries right around the world, like the UK, like Australia, like Africa and Asia, the incidence went back up again as people were spending more time in close proximity to others and coughing on them or whatever else, breathing on them. So the incidence of meningococcal B is by far the most important in Australia, and it's the most important in many countries around the world, but not all. For example, at the moment, it's not high in the US, but in many parts of Europe, it is. The number of cases that occur in Australia over the last 3 years is about 125 per year, of which about 100 are meningococcal B or slightly more. We're expecting the number to be even higher again this year because we've only got 6 months data, but it's suggestive that it's going to become more common again this year than last. So it's something that we're wanting to pay closer attention to now, and we'll only know by doing close surveillance. But that's what we're doing in Australia very well. We've been doing good surveillance since the 1990s.
And Robert, I mean, the numbers sound low, but is there deaths associated with this infection? And if so, is it more in certain age groups?
Yes. The mortality rate is about 5 to 10%. And another 30% or so are left with major long-term complications, sequelae, whether it's scarring, amputation, psychological disorders, deafness, and so on. So although you only have maybe 125 cases, a big chunk of those, 40 or 50, have got serious consequences. As I said, 5 to 10% dying, and another 20, more like 30% with long-term serious sequelae.
That is actually a major problem, to have 30% having long-term sequelae, and I've unfortunately seen this clinically when a child has got this and resulted in amputation of distal limbs due to the disease. The good news is this infection can be prevented, but before we get to that, last question for the moment, Robert, are there certain populations that are just at highest risk for the invasive meningococcal disease, especially from MB?
Yes, there are certain populations. Australia's been very good at introducing new vaccines, especially for high-risk groups, and that includes Aboriginal and Torres Strait Islanders, who have a risk around 4 times higher or the general population of getting invasive disease. If you're under 2 years of age, your risk is much, much higher, whether you're Indigenous or not. If you're between the ages of 15 and 24, there's a secondary peak. We did a lot of research on that in the UK again, and we actually followed up hundreds of teenagers and later hundreds of children who survived meningococcal disease and saw how much detriment, how many children and teenagers were affected in the long term. So although the numbers are relatively small, a very high proportion of those who get disease get real serious problems.
And it's thanks, Robert, and it's good to see the audience is getting involved already, panel members. I've got a question already. does invasive meningococcal disease happen soon after infection, or is there a latent period?
I'll happily answer that. I've worked with a lot of people who've done not just disease studies, but also carriage. And again, during my 15 years in the UK, we were able to show that the great majority of children or teenagers that acquired meningococcus were usually within 3 days of the exposure, at most about a week. There was 1 or 2 cases documented where a teenager acquired carriage and carried the germ for a year before it led to invasion into the bloodstream to cause disease. But that is the exception. The rule is to proceed from transmission to carriage to disease within days.
Thanks, Robert. And before I move on to the next section, I'm just interested to know from my panel if any of them have experienced seeing patients with meningococcal disease, whether it be younger children or adolescents.
I'll answer that one first, if we like. This is the problem with this disease. It's extremely rare that children get sick quickly. And yes, I have seen in my hospital career children with meningococcal disease, but fortunately not in my general practice. But this is the problem. In general practice, you've always got to have this on your radar because it could walk through the door and the child goes from well to sick. It's like someone accelerating fast, within 12 hours that child could be moribund. So this is where we've got this real challenge of working out, is this just another viral illness that will settle with time and no specific intervention, or is this meningococcal and you need them in the hospital as fast as possible?
Mm.
Yeah, I think we're very fortunate as healthcare workers that we do come across families, unfortunately, who get these diseases. And I've certainly seen infants admitted to our intensive care unit with meningococcal B disease. And I recently just met, as Robert was saying, a young adolescent female who had meningococcal disease as an infant and has now subsequently lost her hearing.
Mm. Yeah, so yeah, my experience has been, like I mentioned earlier, with the younger child who had the bad outcomes. But I've also been indirectly involved where there's been a teenage uni student who contracted meningococcal disease and died because they had been in the student residences and they had thought they'd had a flu and not really told anyone about it. So very tragic. So this is a terrible condition, but we have an opportunity as healthcare practitioners to prevent this happening. Leanne, could I ask you to summarize the key eligibility groups for vaccination? Because we now have vaccines, of course, under the National Immunisation Program. And who are the key eligibility groups?
So under our NIP program, we have it funded for, as Robert mentioned, the Indigenous children under the age of 2, which is really great. And I think I'd like to remind my fellow practitioners listening that always check about people's Indigenous status when they enrol in your practice and when you're reviewing them with their childhood vaccinations, because you may not be aware, they may not have volunteered it. And that is important to check that, because that's a group that can have it. There are those people with some rare and unusual conditions to do with their spleens and complement, and I think I would refer anyone to the handbook to look to see those, because it's such a small group. And most practices, like Spleen Australia, their splenectomized patients are always advising them about that. There are some states that have programs. South Australia led the way in that, and that's really great. They have an infant and a teenager and adolescent program, as does Queensland and the Northern Territory. The other states have yet to follow. I'm in a state that's holding an election, and maybe we might be getting one subject to who wins government. But everybody else falls outside that and has to look at it as a private.
Mm. So we might get into the funded programs a little bit later, but thanks for bringing that up, because that is important. Leanne, what has been the effect of adding the quadrivalent vaccine to the NIP? Because that was quite a big thing when that happened, isn't it?
Yeah, I remember when we just added the MenC and we had a good dramatic drop in meningococcal C, which was really great. And then, like more recently, we've now got the ACWY, and because, of course, there was a resurgence of W, I think, from memory, and so that has been dropped that right off. So most of the cases now we are seeing are actually B, or sometimes untyped for all sorts of reasons that they can't give it a code. But I think Robert alluded to something like 2/3 of them are E's.
Mm.
But yeah, it was very dramatic when it was introduced, much to our pleasure, but it made it even rarer and harder to pick the cases when they came through.
Yeah. And do you expect if MenB was added under the same eligibility criteria that we might see a similar impact?
I think we would see a similar impact. Certainly South Australia, who has had the program for the longest, have seen that impact. So.
Okay.
Yeah, South Australia have just reported that their infant program in babies, following the children for 5 years, there's a very high level of protection. And the using 2 doses in teenagers is also a moderately high level of protection from that as well.
So perhaps South Australia is sort of an exemplar of how things can be, where we can change transformation through a relatively simple change, isn't it? So, Leanne, you're a busy clinician. How would you or Sonia, both of you, see patients that are in these eligibility groups? How would you identify eligible patients in your practice?
I think it's really important, first of all, with the infants coming through, that when they're coming into the clinic at that 6-week mark for their 6-week check, and to start to talk about their 6 to 8 week vaccinations. So I think it's our duty as health professionals looking after them to tell them about these vaccines. As I say, see if they are eligible. If you happen to be, of course, in one of the fortunate states, that's easy, or checking their ATSI status and advising them of the vaccine, and this vaccine is available, because we mustn't be the ones that judge the cost of the vaccine. We must sort of give the parents that opportunity to be aware that there is a vaccine that exists, because much is lost by not telling people and not informing people. And you all have heard stories about people who haven't had the vaccine, developed meningococcal B, and have said, nobody told me there was a vaccine that I could have chosen to have.
Yeah, again, working at the Children's Hospital, I'm very fortunate because we have a host of clinicians who look after these vulnerable patients. So I've done a lot of work with our Wodja Health Clinic, which is our Aboriginal liaison officers. And so each week when they've got patients coming to their clinic, they're all eligible for meningococcal B. So there's a funded program for children under 2, but the Children's Hospital actually funds it for Indigenous children up to 18 years of age. So if it's not NIP funded, the hospital will then fund it. So I meet with the Aboriginal liaison officers each week and flag all of their patients for meningococcal. And if their clinicians send them to our immunisation centre, I take chocolates round to thank them for doing a great job. In terms of our other patients who are medically at risk, we have children with sickle cell disease who will, go on to be asplenic, and we treat them as asplenic. So again, we build really great relationships with our haematology. We have a sickle cell nurse, again, that we can contact and send all of their patients through. So we get really good uptake of our special risk patients. We work with our transplant coordinators to make sure that our immunosuppressed patients get meningococcal. So we really have quite a high uptake. I think it's definitely difficult to measure. It's not like everybody flags special risk groups on the AIR. So I think it's quite tricky to actually get some measure of how we're doing with our special risk groups. But I think at a local level, we know that we're doing quite well in that space.
Yeah, those sound like very good measures, Sonia. You're obviously working in an environment which is very proactive. This question can be for either Sonia or Leanne, and then I'll move to an online question. What are the current Australian immunisation handbook recommendations for MenB vaccination outside of the NIP?
It is actually recommended for all these people that we've been talking about. So this is recommended but not funded. And I think that this is where we often run into this difficulty in our mind. If it's not funded, it can't be important. But it just means the government hasn't got money to pay for it. But recommended is a very panel of experts have gone through all this and have looked on what is recommended. So it is recommended for children under T and for teenagers in their adolescence. Plus, of course, they're medical at risk. And you could actually, arguments for a number of other people to consider it. Anyone who's living in cramped conditions, such as boarding houses, dormitories, this sort of thing, where the social distancing is a lot less.
Yeah, and as I mentioned, the organ transplant patients, so solid organ transplant patients, they're not funded for meningococcal B disease, but in the immunisation handbook, it does say for those that are immunosuppressed, and that is also for patients on any other immunosuppressive medications, so patients with Crohn's disease or arthritic conditions that are on immunosuppressive treatment. So the immunisation handbook recommends it for anyone who's at increased risk of meningococcal disease. Also, laboratory workers handling Neisseria samples, they're also recommended but not funded. So there's the handbook is very clear who is recommended for, but as you say, there's some funding discussions.
Yeah, and we always have this disparity, don't we, with newer vaccines where we have the funded versus non-funded. And it causes us to have much angst, those who work in immunisation. This is a question from online. For the MenB vaccine, how long does protection last? I presume this is someone who's been fully immunised according to protocol.
So the protection is likely to last about 5 years, but it's only been used widely in one country, the UK, since about 2015. So we're still generating more information and data, but there's certainly evidence of longer-term protection in the UK, but after 5+ years, antibody levels are declining, and so people suppose that they may need a booster. That's not confirmed as yet. So for the moment, we're looking at protection for a minimum of 5 years, and there's data from South Australia in infants to support that. And as the next few years pass by, we'll get clearer data on whether the protection can be relied on out to 10 years.
Okay, so roughly 5 years at the present, and perhaps data later regarding booster. So we alluded to funded programs. Now, unfortunately, we have this situation where some states have funded programs for under 2-year-olds, such as South Australia, Northern Territory, and Queensland. And there are funded programs as well in some states for Year 9 and Year 10 to capture the adolescents. Why are the other states lagging behind? This seems very strange in a federation where all states should be doing the same thing, surely.
Yeah, I certainly think we should have a national program. Unfortunately, it has been submitted to PBAC multiple times and has not been approved for the National Immunisation Program, which is, I think, why that has prompted the states to take their own action. I think the South Australia certainly kicked it off really because they had much higher incidence per population. So they took a really proactive approach to funding the program there. And then, of course, Northern Territory and Queensland have followed. I would love for it to be funded in Victoria, of course. It does make it a lot easier. But, as I said, it's very hard to get meningococcal vaccines funded on the NIP. Back in 2003 with the meningococcal C program. It really, again, didn't make sense financially for PBAC to approve it either. It really bowed to public pressure. So, the high incidence of MenC at the time and parents, lobbying for the vaccine to be approved. And I certainly think in 2016, when we had the death of a young boy, Matthew Wilkins, at a high school from meningococcal W, prompted Victoria to fund the meningococcal ACWY vaccine in 2017. And then it was actually funded on the NIP a bit after that, like the following year, I think 2017. So I think there's definitely a role for public pressure to put on to government to fund these sorts of programs. I think, as Robert said, the incidence in Victoria, the numbers are low. We've had 19 cases in the past 12 months, with 74% of those being MenB. And so parents will say, well, if there's only 19, that's not really high numbers, but we don't know who those 19 cases are going to be. So, that's why we have a national program. We want to make sure everyone's protected, because it only takes for one child to either die or end up with severe sequelae for it to matter. And every life matters.
It's pretty sad that it needs to be a death to cause change, though, isn't it? Yeah.
That was observed in Queensland, where the health minister in Queensland met with one family who'd been bereaved of their 23-year-old daughter, and another family whose teenage daughter had been severely affected and had fortunately recovered, but with chronic organ dysfunction.
And unfortunately, we twice had programs in that same, funded by the state for first for MenC, and then later on for ACW because of increased death rates in a small population. But, state governments, just like federal governments, only have a limited bucket of money, and sometimes, people might say, oh, Tasmania's only a small state, you can probably afford it. But we may not be able to afford it because we only have a smaller bucket of money and less wriggle room in the immunisation budget, because that's where these extra programs get funded, out of a little bit of wriggle room in the budget. So I know, having been on committees that do that, there isn't a lot of that extra excess to be able to fund these programs. And these vaccines, unfortunately, aren't cheap on a mass scale.
And we did get a question from online on how much it costs. It does cost about $130 per dose, and it's a two-dose course. So yes, not cheap for those buying it privately. So it is a barrier for us, isn't it?
12 months. So if you're having it, from 6 weeks, it's a 3-dose course.
So it depends on when.
But the point of having it from 6 weeks is that the age at which the disease is most common is 3, 4, 5 months of age. So delaying a vaccine till 12 months, you're missing out on providing protection for when babies are most at risk.
You can use some sort of analogy. Sometimes grandparents are happy to fund it, this sort of thing. So, parents still get baby bonuses and things like that. So it's probably the teenagers it's a little bit harder to get the sort of, funding for that. And that's a group that we spend a lot of time concentrating on, these gorgeous little babies and the nurse talking to them when they're having their other vaccinations. But the teenagers are notoriously under-vaccinated for lots of things, not their other routine funded vaccines they're often get behind in the school-based programs. So adding a non-funded vaccine in there is probably something we have to remember to talk about.
Leanne, I believe the Northern Territory has a funded program. And how successful has that been? Are you aware?
I'm not fully aware, but I believe it is very similar to the South Australia. And there's also some interesting work about crossing over with preventing gonococcal infection. So that's a watch this space one for teenagers, which could be very interesting.
So, Sonia, you mentioned earlier about Victoria not having a funded MenB program like Queensland, for example. How does that impact your interaction with parents or, patients potentially who are in those risk groups? in their discussions around vaccination and ability to pay?
Yeah. It doesn't really affect my practice because whether it's funded or not, I'm going to talk to families about it at 6 weeks. So the beauty of it is if it is funded, of course, then it's the difficult decisions taken away from the parents. So for me as an immunisation provider, I'll be having the conversation with families, as Leanne said, at 6 weeks, at 4 months, in adolescence. It is really important to talk about meningococcal because, and as Leanne mentioned, families that you see who end up in intensive care say, why didn't somebody tell me this was preventable? So I absolutely see it as my role, whether it's funded or not, to be having conversations with families at 6 weeks and when they first present, and again at 4 months. I never assume that if I haven't seen them the first time, that someone else has had that conversation. And as I said, it's really just up to the parent then to decide whether or not, to pay for the vaccination. But I think one of the important things, and I always sort of talk about this, is Helen Marshall has actually published a paper on recommending an unfunded vaccine, and people just assume that cost is prohibitive. So that makes them avoid having the conversation, but I can't really worry about that. My job is to really talk about the disease and that it is preventable.
So this question is really to all three of you. From your perspective, from different clinical scenarios, are parents and adolescents aware of meningococcal B disease and that there is a vaccine available? So we might start with Robert.
Fairly straightforward answer. Some people are aware, teenagers and young adults, but the majority, I suspect, will not be. Most people aren't aware that there are two vaccines, one MenB alone and one ACYW. We're not far off, a year or two away from having a combined ACYW with B, but it's not available yet. People are asking about that in the chat. So most people aren't aware that there are two vaccines, and the MenB one is really important because it's so much more common than ACYW. We've had a tremendously successful campaign in Australia. Meningococcus A really started going away in the 1970s. As Leanne said, meningococcal C, when we introduced vaccine in 2003, within 10 years, it was 96% reduced. We introduced ACYW nationally in around 2018. W is very uncommon now, and Y is only really seen in some adults with genitourinary infection and very rarely with pneumonia or septicemia. So we've really got one big problem to deal with, and that's MenB, and that's what we need to raise awareness of so people can get protection for themselves and for their families.
And I think it's an exciting prospect that we're going to have a combined vaccine in the near future.
Absolutely. We just have to wait and see about that.
And we shouldn't put off vaccinating, waiting for it. Because I think awareness gets raised when, unfortunately, there's a case which results in a death. And that makes the headlines in the newspaper and on the TV. And that's when people suddenly become aware of it. I remember when we had the outbreak in Tasmania in, I think it was 2000, and people were suddenly, everybody knew about the cockles and, and how you could transmit it, and every rash was brought to the general practice because we had an excessively high number of cases that was seen at that stage. But that's what raises awareness. But really, that's not how we want to raise awareness, by people actually dying from the disease.
Yeah, and I agree with Robert. There's really almost two schools of thought. There's some people that are really aware of the vaccines that are available, and it depends on who's had those conversations. Usually it's other parents who've gone through and got it for their child, so messages keep coming through, or maternal child health have started the conversation. But yeah, you also have this other group of families who say, oh no, we've had the meningococcal vaccine, and it's like, yeah, the one at 12 months and the one in year 10 at school, but thinking that that's covered them against all meningococcal strains, not being aware that there's this separate vaccine for meningococcal B.
And you can have that ACWY down to 2 months as well. That's privately funded, but needless to say, it is an option to discuss with.
So I guess we're seeing that it's very important, this topic of awareness. Is there enough information, do you think, for healthcare practitioners and the general public on meningococcal disease? And if not, how would you like to see this improved? So we might start with Sonia, and then we'll open it for the other two to answer on this.
Yeah, I mean, as I say, I think there's enough information about meningococcal. I certainly think parents worry about meningococcal, but as I said, I think there is this level of confusion about there being the two separate vaccinations, which I certainly think that will be the beauty of having one combined vaccine that protects against all serotypes. I think for healthcare professionals, I think it really is important that we talk about meningococcal, think really from 6 weeks of age rather than waiting till 12 months when we're having the meningococcal ACWY. I think a lot of it comes down to clinicians not feeling comfortable to talk about it because it's not funded. As I said, we know that when you have recommended an unfunded vaccine, that most people don't talk about it because they worry that they're trying to sell somebody something. They don't feel comfortable about it being not, provided. And for families too, when something's not provided by the government on the schedule, then they think it's less important. So, and that's a real challenge for us as well.
Leanne?
Yeah, I say, and maybe, and I have heard Paul Van Bynert say we should be starting this conversation when the mother actually comes to you at the antenatal checkups, that as well as talking about her vaccines, because we've increased the vaccines in that space, but actually that there will be vaccines for her baby, some of which will be funded and some of which won't be, but making her aware of them, that we will be offering them when the child is 6 to 8 weeks. So I think that conversation needs to start really early and be part of what we have. And I guess evenings like this, where we're actually talking to our colleagues and informing them and helping them to understand some of those things that the public at large is not aware of. So there are good information brochures provided about meningococcal B vaccine now.
And Rob, any comments?
Nothing more to add. I'm happy to deal with some of the questions in the chat, but you keep leading.
Yeah. So we've had a interesting comment in the chat here. It's very disappointing to hear of a colleague who actively asked her GP for MenB script for her infant's 2-month and 4-month visit, only to be told each time it wasn't needed because it wasn't on the NIP. Very disappointing.
That is disappointing. When you look at the immunisation handbook, both meningococcal B and the combined ACYW vaccines are strongly recommended for anyone who would like to avail themselves of that protection, and especially strongly recommended for babies under 2 and for teenagers 14, 15 years of age and above. So they're both strongly recommended, just that one is funded and one isn't. And that, as Leanne and Sonia have said, leads people to think that it's not as important, but it remains important.
And it could be also just that general practitioner not being aware that they're probably just thinking this child's not in a risk factor in the sense that they're not Indigenous, so therefore, oh no, you don't need to worry about it. That's only for Indigenous children. Just, that's just the funding category, And we've seen this before with, pneumococcal when it first came out. People thought, oh no, that's just for medically at risk. We've seen it with influenza because we used to have just a program that was funded for medically at risk infants. Then we brought out a much broader program for all children, 6 months to 5 years. So people said, infants and children, oh, and if you're not in a risk, you don't have asthma, you don't have chronic lung disease or a heart problem, you don't need to have it. So that's the problem when you have, specific funded categories, when it's really recommended for all infants and adolescents.
Thanks, Sonia. There's a very interesting question here. Is it only a disease of young children, or does it equally affect adults and the elderly? Are nursing home, i.e. institutional setting, a high risk for the residents?
If Leanne will let me answer that.
Yeah.
The risk of disease in the elderly is relatively low, but they can get pneumonia, especially caused by meningococcus Y. But we don't have a sufficient concern about the number of cases to want to see vaccination in the elderly. Young adults up to the age of 24, 25 are part of that second risk group. And Leanne mentioned if they're living in closed, crowded conditions, and that also includes people living with others who are smoking. That's another risk factor for young adults and older teenagers. So what we find is that the rate of carriage of the bug decreases rapidly from the teenage years through the 20s and 30s. And so you're less often exposed to it and you less often get serious invasive disease the older you get. So the sort of upper limit for for people getting vaccinated is 24. And that applies too for people who are going overseas for periods to places where there's higher risk of meningococcal disease, like meningococcal A in Africa, A for Africa, I like to say. And they are another group, people under 25 tripping to Africa for at least a few weeks. Meningococcal ACYW is a worthwhile vaccine for them.
Yeah, thanks, Robert. That's actually answered one of the questions that was in the chat. So there's a comment here. I am in Victoria and financial consideration is a big issue for a lot of families. What is the effectiveness of 1 or 2 doses compared to the 2-dose pre-12 months and a booster after 12 months?
So the infant program, if you're doing the vaccination at 6 weeks and 4 months, that'll give you good protection in that sort of short term. But the booster from 12 months of age is really to give you that longer term protection that Robert was talking about, sort of, out to 5 years. So, if you've only got children who are having, the 2 doses from 12 months of age and they're only going to get 1, I mean, the advice is to complete the course. I certainly think you shouldn't not complete the course due to cost. Robert would know the degree of protection following 1 dose, I'm sure, but I'm not sure. But the advice would be to complete the course anyway. Don't start it if you're not going to complete.
And the other thing is these programs for when to vaccinate in terms of the intervals were all developed based on the clinical trial protocols. And during the clinical trial protocols, they also measure immunogenicity, and they have some level of confidence around how much immunity is provided by following that program. So there is data available on how much immunogenicity after 1 dose versus 2 doses. And the recommendations we have is based on the best levels of immunity provided from that particular intervals. So
that's right, Roy. One dose really isn't enough.
Yeah. So this is an interesting question. Is there a potential issue with serotype shift as the current illness producing serotypes are vaccinated for, as with pneumococcal?
The serotype story with meninge is quite different to pneumococcus. The replacement and the changes that occur with pneumococcus are much more rapid because there are over 100 serotypes, whereas for meninge there are only 13. And what we see decade after decade is pretty much the same. ABC has been pretty important. More recently, Y and W, and also X has come up in Africa. So there is change in serotype happening, yes, and we've been observing it especially in Africa, but it's not nearly so rapid or prominent as it is with the pneumococcus.
So let's move on to a discussion of side effects, because this is a common question that parents or people contemplating getting vaccinated often ask. So what are the common side effects of MenB vaccination, and what measures do we have to reduce the side effects? I might start with Sonia and then move to Leanne.
Yeah. So we know through the clinical trials that the side effects from the meningococcal B vaccine, particularly in children under 4, is a temperature, so a high fever, and of course local reaction at the injection site. And so for that reason, children under 4 are sometimes at risk of febrile seizures, which can occur obviously following vaccination when you get a high temperature. So the advice is to give paracetamol 30 minutes prior to vaccination, and then a further dose of paracetamol 4 hours after that first dose, and then a subsequent dose of Panadol 4 hours after that. So a total of 3 doses at 4-hourly intervals following the vaccination. In children older than 4 years of age, then there's no real need to give the paracetamol, just symptomatic treatment. So if the child has got a temperature and is a bit grizzly and what have you, then you can certainly give paracetamol. In the adolescent population, they sometimes get some other systemic side effects like headache, and again, some paracetamol or ibuprofen would be appropriate in those instances.
That's a fairly comprehensive answer, I think. Anything to add, Leanne?
No, not really. And I was just saying that's the important thing. In fact, our nurse is very strict about the paracetamol, and we actually carry some paracetamol in the clinic so that if a child hasn't had their paracetamol, we give it to them and ask them to go and take a seat in the waiting room until the half hour's up or close to.
Yeah. So, Leanne, whilst I have you, I might ask you a question about opportunistic discussions. You mentioned one earlier. In clinical practice, what do you think would be our opportunities to have those opportunistic discussions on MenB vaccination in particular?
So I think the antenatal visits, the routine sort of checkups with the children, and the adolescents, if you're lucky enough to get an adolescent in front of you, I think that's a reasonable thing to talk about with them, particularly because you'll be asking them, are they up to date with their Gardasil, their pertussis? So it's quite reasonable to say, and the meningococcal ACW is funded for teenagers, so it's an opportunity to just discuss that at pretty much everything. I mean, every consultation should potentially be an opportunity to discuss relevant immunisations for that particular person in front of you. And a lot of our software has prompts. I don't think I've seen a prompt for meningococcal, but we certainly have prompts for influenza and pneumococcal and zoster. So I think that we probably should be talking to the software providers about putting some of these other prompts in there. But every consultation, it's part of good health checking.
Yeah, I think that's an excellent suggestion, Leanne, about having that conversation with the big software providers like Medical Director and Best Practice about putting prompts, because that will get the providers thinking about it, isn't it? Sonia, you have a key interest in vaccine hesitancy, and we have encountered a bit of this, unfortunately, post-COVID, as we're all aware. Vaccine hesitancy doesn't discriminate. It affects all vaccines. And it's probably been responsible for a lot of the decline in vaccination rates, particularly in younger children. Is this a similar case for meningococcal vaccination as well, that we're getting vaccine hesitancy?
Yeah, good question. I think in terms of vaccine hesitancy, the two things that people worry about the most actually is tetanus and meningococcal. So even in, vaccine refusers, they'll be the two sort of diseases that they're particularly worried about. I think because tetanus, no matter how much you wrap your child in a cotton wool, like they're still going to play outside and potentially, injure themselves on something dirty. And with meningococcal, it's kind of the same thing. They're more worried because it's such a devastating illness. So when you type in Google meningococcal, I mean, the pictures you see, can be horrendous, and the stories and those sort of things in the media about meningococcal are devastating. And so people do worry in particular about that sort of disease, I think. So I think that vaccine hesitancy for meningococcal probably isn't in the same space as some of the other immunisations. In saying that, though, we have seen a decline in the Year 10 vaccination of the meningococcal ACWY. So I think there has been some issues around uptake of that particular one in Year 10. I'm just not sure whether it's because Year 10 is just a tricky age group to get kids through the school program, with more just a compliance issue rather than hesitancy. Because if you're able to explain to people about how meningococcal is spread, as Robert mentioned earlier, it's kids kissing other kids. Parents know that's an issue in high school, so you can usually quite easily convince them to get the vaccines.
And with those difficult patients, Leanne, who are, dare I say it, anti-vaxxers, but who have a small child who is in this at-risk group, is there some pearl of wisdom you can give us that can help get them across the line and consider vaccinating?
I don't know if I've got any pearls of wisdom, but I think informing people and providing people with the information, and there's some good resources attached to the handbook for helping people understand about vaccinations. And I think you've got to have those conversations. Sometimes they'll be a lot longer than those conversations you'll have with the child. Parent who arrives and says, "I've got little Sophie here and she's due for her vaccinations," and you'll explain to her what she's going to have, and you'll talk about common side effects, and it'll all be, the parent has come in the door expecting to go out with band-aids on the arms or legs, depending on the age. But, these conversations about and people just want to understand and know what about vaccinations, and, what they've been extensively tested and researched. And I think I'm with Sonia about there are some things that people worry about a lot more. I had measles when I was a child and I'm still here. But, meningococcal is, everybody sees that as deadly and devastating. And likewise, tetanus, if people have, I've seen 2 cases of tetanus in 40-something years. So, both of them were in intensive cares.
Yeah. But this is probably the last question I'll take from the online, but I think it's a particularly important one. It's, I guess, because the initial illness can masquerade so many other things. The question is, what would alert the doctor about a patient suspected of an acute infection? And if suspected, should they be giving IM ceftriaxone before referral to ED? Does anyone want to answer that one?
I'd love to answer that. That's another thing that we did a lot of research on. The initial symptoms are obviously a high fever, which has been discussed, but there can be the symptoms of meningitis, where you have headache and vomiting and stiff neck. But, more than half don't have meningitis early on. And so you can't dismiss a case because it doesn't have meningitis symptoms. So you have to look also for the symptoms of blood poisoning, and that includes the petechial rash, fine spots that do not disappear when you press a clear glass against them on the arms or the legs or even the abdomen. And that brings me to the importance of a full examination of the skin to find places where the rash might be manifesting, not just on the peripheries. So what we also found in both children and teenagers was that they had other symptoms which were suggestive. So they got their cold hands and feet. The reduction in blood flow to the periphery meant that the fingers and toes actually felt cold. And before the petechial rash developed, they got another rash which was actually able to be pressed on, and the colour would go away. So you need to watch for that. One other key thing is leg pain and abdominal pain, and sometimes with diarrhea. So with the meningococcal W135 10 years ago, there was a bit more in the way of vomiting and diarrhea with those cases too. So it's really important to suspect it. Any one GP might only see 1 or 2 cases in their career, so they need to have information far in excess of their experience in order to be able to recognise a case. And so it's really quite tricky and a real challenge for GPs. But what they should do once they've recognised a probable case is not only consider giving ceftriaxone, but not intramuscularly, but if they can get a Venflon in, an IV cannula, and give it intravenously, that's much more rapidly effective, and it's actually what's recommended.
Thank you very much, Robert. We're pretty much run out of time. I'll very quickly go around the three panelists. Last single key message takeaway, Sonia.
Look, I think we've covered a lot tonight. I guess my only just sort of final note would be that the Immunisation Coalition actually have a meningococcal disease guide. So I think for clinicians, if they are interested in having a bit of more step-by-step approach on how to have conversations with families, then I recommend that they, tap into that resource.
Thanks. Leanne?
I think just important to have that conversation. So talk about the vaccines, talk about the fact that recommended is what in the handbook is what we should be going by.
And Robert?
I'll maybe quickly respond to something in the chat. Upper age limit for MenB vaccination, I'd certainly be using it in the 20s, but as someone who doesn't have a spleen in their 30s or 40s, I still would think vaccination would be appropriate. Just check the handbook for that point. And infants coming at 6 weeks for vaccination, there's the NIP chat, or even at 8 weeks. Then it says, plus men ACYW, you don't need that vaccine at 6 or 8 weeks. You don't need it until 12 weeks. RSV, you don't need that vaccine at 6 or 8 weeks if your mother was vaccinated during pregnancy against RSV. So MenB is the only one there that at 6 to 8 weeks where there's real benefit against disease that's currently occurring in Australia. Thanks.
Well, I'd like to thank all the panel members for providing their input. I think we've had a very comprehensive cover of MenB and meningococcal disease in this short time. I'd like to thank the audience for their interest and engagement. Remember, this webinar has been recorded and will be available on the Immunisation Coalition website in about a week's time. And there are also future education events on the website, so be sure to have a look. And we will be sending you a small evaluation survey, and your feedback is really important to us as we strive to bring high quality education to healthcare practitioners. From myself and the panelists, thanks for joining us tonight, and see you again next time.
Bye-bye.
Thanks, everyone. Bye.
Bye-bye.